Hyponatremia, low sodium. Paramedics arrive at the home of a 72-year-old man. His daughter called because he was acting strangely. They find him slumped on the couch. His clothes are damp with sweat, and his skin looks pale and gray. He seems confused, repeating the same words over and over. His hands tremble when he tries to lift a water bottle. His daughter explains that he's had 3 days of nausea, vomiting, and diarrhea. He has been drinking large amounts of plain water to stay hydrated, but he has barely eaten. He usually takes a thiazide diuretic for high blood pressure and an antidepressant, an SSRI. Recently, he has seemed weaker and is stumbling when walking. The paramedics note his dry lips, muscle twitching, and occasional spasms in his legs. He is disoriented and slow to respond. His blood pressure is 90/60. His heart rate is 110 beats per minute. His skin feels clammy. During transport, his level of consciousness declines further. His eyes roll back, and he has a short tonic-clonic seizure. The team secures his airway, gives oxygen, and prepares intravenous access. At the hospital, they report elderly male, gastrointestinal fluid losses, excessive water intake, and medications that predispose to low sodium. Found confused, with tremors, and seizure during transport. His labs show serum sodium at 118 millimoles per liter. The physician explains, sodium is the main extracellular ion that regulates water balance. When sodium drops too low, water shifts into the cells to equalize osmotic pressure. In the brain, this causes swelling, which leads to confusion, tremors, seizures, and decreased consciousness. His thiazide diuretic increased sodium loss, vomiting and diarrhea worsened it, and drinking excessive water diluted the remaining sodium further. His blood gases show a normal pH, so the ABG is not contributory. Classification of hyponatremia instead focuses on serum and urine osmolality and urine sodium in advanced practice. The treatment plan is to give 100 milliliters 3% sodium chloride bolus over 10 minutes. Repeat up to 2 more times if symptoms persist. After boluses, limit sodium correction to less than 8 to 10 millimoles per liter in the first 24 hours, and equal to or less than 4 to 6 millimoles per liter in high-risk patients, such as those with alcoholism, malnutrition, liver disease, or hypokalemia. Consider a desmopressin clamp to prevent overcorrection and reduce the risk of osmotic demyelination. They monitor his neurological status closely, correct the underlying gastrointestinal losses, and hold his diuretic until he stabilizes. Hypernatremia, high sodium. Paramedics are called to the home of an 80-year-old man. His neighbor says, he's been confused and barely drinking for days. He lives alone, and it's been very hot this week. When the paramedics arrive, they find him lying on the couch, drowsy and restless. His lips are cracked, his tongue is dry, and his skin tinted with poor elasticity. He mutters incoherently and struggles to follow commands. On exam, his eyes appear sunken. His muscles twitch intermittently, and he flails weakly when they try to sit him up. Vitals are called out: heart rate 120, blood pressure 85/50, respirations 26, oxygen saturation 96%. During transport, his mental status worsens. He becomes lethargic, then briefly seizes. Oxygen is applied, intravenous access is secured, and they begin fluid resuscitation. At the hospital, the handoff is given. Elderly male, found dehydrated, confused, with seizure en route. History of poor intake, hot weather, and likely inadequate access to water. Tachycardic, hypotensive, dry mucous membranes. Suspected hypernatremia from dehydration. His labs confirm it. Sodium is 164 millimoles per liter, severely high. The physician explains to the residents, sodium is the main extracellular ion. When sodium is too high, it means the body has lost more water than sodium, or taken in excess sodium. The high extracellular sodium pulls water out of cells, shrinking them. In the brain, this causes lethargy, irritability, seizures, even coma. In this patient, poor fluid intake during heat likely caused free water loss and hypernatremia. His hypotension and tachycardia also reflect volume depletion. Treatment begins carefully. The priority is to restore intravascular volume with isotonic saline if unstable, then correct free water deficit slowly. Rapid correction can cause cerebral edema. The plan is to replace water gradually over 48 to 72 hours, monitoring neurological status and electrolytes closely. The nurse reassures his neighbor. His sodium is very high because he became so dehydrated. We're giving fluids carefully to bring it down, but not too fast, because the brain needs time to readjust. He should improve as his sodium comes back to normal. Hypokalemia, low potassium. A 65-year-old man is found slumped beside his bed. His wife tells the paramedics, he's been too weak to stand. He's had stomach flu for days and keeps vomiting. The paramedics find him alert, but very weak, with shallow breathing. His arms and legs twitch off and on. They observe flaccid muscle weakness in his legs, fine tremors in his hands, and shallow, irregular respirations. His skin is pale and sweaty. They call out the vitals. Heart rate is 128 beats per minute, irregular. Blood pressure is 95/60. His wife adds, he takes a water pill, a loop diuretic, for heart failure. And he hasn't been eating much because of the nausea. During transport, his heart rhythm suddenly becomes irregular. On the monitor, premature ventricular contractions appear. The team gives oxygen, starts intravenous access, and radios ahead. Possible electrolyte abnormality with cardiac involvement. At the hospital, the handoff is given. Male, 65. Vomiting for several days. Loop diuretic use. Weakness and tremors. Irregular tachycardia with PVCS en route. Currently stable, but very weak. The labs confirm it. Potassium is 2.4 millimoles per liter, severely low. The physician explains to the residents, potassium is vital for the resting membrane potential in both muscles and nerves. When it drops, cells become hyperpolarized, harder to depolarize. That's why he's weak, with tremors, shallow breathing, even risk of ileus. In the heart, low potassium increases risk for arrhythmias, PVCS, tachyarrhythmias, even ventricular fibrillation. His diuretic and vomiting both depleted potassium, and his blood gases show a mild metabolic alkalosis, which pushes potassium into cells, worsening the deficit. Treatment begins immediately. 4 potassium is never pushed. It is always diluted and given slowly, with the maximum rate depending on IV type and institutional policy due to the risk of cardiac arrest. Rates and concentration depend on line type and local policy, and require continuous cardiac monitoring if faster infusions are used. He is placed on continuous cardiac monitoring. Oral potassium will be added when he can tolerate it. His diuretic regimen will be reviewed, and antiemetics are started to control vomiting. Magnesium levels are checked, because if magnesium is low, potassium replacement may not work. The nurse reassures his wife. His weakness and irregular heartbeat are from very low potassium. We're replacing it carefully through the IV. It has to be slow, but you should see him start to regain strength. Hyperkalemia, high potassium. A 58-year-old man collapses in the waiting room of his dialysis clinic. Staff quickly call paramedics. They explain, he's missed 2 dialysis appointments this week. The paramedics find him drowsy but responsive. His skin is warm and clammy. He complains of weakness and tingling in his hands. He is breathing rapidly and deeply, indicating compensatory hyperventilation. They observe muscle weakness in both arms and legs, tingling around his lips and fingertips, and a weak, irregular pulse. Vitals are called out, heart rate 42 beats per minute. Blood pressure 85/55. Oxygen saturation 94%. During transport, his mental status drifts. On the cardiac monitor, his T waves are tall and peaked, and the QRS complexes are beginning to widen. The paramedics place pads for possible pacing or defibrillation and radio ahead. severe bradycardia, likely electrolyte disturbance, history of kidney failure, missed dialysis. At the hospital, the handoff is given. Male, 58. End-stage renal disease. Missed dialysis. Found collapsed with weakness and paresthesias. Bradycardic with peaked T waves and widening QRS en route. Blood pressure 85/55. Intravenous access secured. Oxygen running. The labs confirm it. Potassium is 7.2 millimoles per liter, dangerously high. The physician explains to the residents, potassium controls the resting membrane potential of cells. Too much potassium depolarizes the membrane, which at first makes nerves and muscles fire more easily. But sustained depolarization inactivates sodium channels, slowing conduction. That's why he has weakness, tingling, and bradyarrhythmias. In the heart, hyperkalemia progresses from peaked T waves to widened QRS to sine wave and then cardiac arrest. His kidneys can't excrete potassium, and his missed dialysis let it build up further. His blood gases show metabolic acidosis, which drives hydrogen ions into cells and pushes potassium out, worsening the hyperkalemia. Treatment begins immediately. He is given intravenous calcium gluconate to stabilize cardiac membranes. Then insulin with glucose, along with nebulized albuterol, to shift potassium into cells. Definitive treatment is dialysis, and nephrology is called urgently. A potassium binder may also be considered. The nurse explains to his wife, his potassium is very high, which can stop the heart if untreated. We're protecting his heart right now, and dialysis will clear the extra potassium from his body. Hypokalemia, low calcium. At a backyard family barbecue, a 44-year-old woman suddenly collapses. Her relatives call 911. When the paramedics arrive, they find her anxious, breathing rapidly, with her hands cramped into a stiff position. Her sister tells them, she's had tingling in her face and fingers for days. She had thyroid surgery just last week. On exam, her hands are locked in a carpopetal spasm, wrists bent and fingers clenched. When the paramedic taps the side of her cheek, her facial muscles twitch, a positive Chvostek's sign. She complains of tingling around her mouth and fingers. She is breathing quickly and shallowly. Vitals are called out. Heart rate is 110. Blood pressure is 100/60. Respirations are 32 per minute. During transport, her muscle spasms worsen. She cannot unclench her hands. The team provides oxygen and secures intravenous access. They note she may be in tetany from low calcium, aggravated by rapid breathing. At the emergency department, the handoff is given. Female, 44, recent thyroidectomy, collapsed with tetany and tingling, hyperventilating with carpopetal spasm and tachycardia. Suspected hypokalemia. The labs confirm it. Ionized calcium is 0.8 millimoles per liter, critically low. The physician explains to the residents, calcium stabilizes nerve and muscle membranes by controlling sodium channel activation. Low calcium makes sodium channels open more easily. That causes neuromuscular hyperexcitability, tingling, spasms, even seizures. In her case, thyroid surgery likely injured or removed her parathyroid glands, leading to low parathyroid hormone and low calcium. Her hyperventilation also caused alkalosis, which makes calcium bind more to albumin, leaving even less ionized calcium available. Treatment begins right away with intravenous calcium gluconate. She is placed on continuous heart monitoring. Plans are made for oral calcium and vitamin D supplementation once stabilized, and endocrinology is consulted to assess long-term parathyroid function. The nurse reassures her family. Her spasms and tingling are from low calcium, worsened by her fast breathing. The fourth calcium should help quickly. You'll see her hands begin to relax soon. Hyperkalemia. High calcium. The daughter of a 71-year-old woman calls for help after her mother becomes increasingly weak and confused. When the paramedics arrive, they find her drowsy but arousable, lying on the couch. She complains of abdominal pain and constipation. Her daughter explains she has breast cancer that spread and high blood pressure. Lately, she's been drinking so much water, but she just seems more tired and out of it. On exam, her mouth is dry, her eyes look sunken, and her skin has lost elasticity. Her muscles are weak, she can barely lift her arms. She is slow to answer questions, sometimes slurring her words. Vitals are called out. Heart rate is 90. Blood pressure is 100/65. Respirations are 18. Oxygen saturation 95%. During transport, she drifts in and out of sleep. Her reflexes are decreased, and her body is floppy when moved. Intravenous access is started, and isotonic saline begun. At the hospital, the handoff is given. Elderly female, history of metastatic breast cancer, complaints of weakness, abdominal pain, constipation, polyuria, and confusion. Found drowsy, mildly hypotensive, dehydrated, possible hyperkalemia. The labs confirm it. Calcium is 3.6 millimoles per liter, severely high. The physician explains to the residents, calcium stabilizes membranes. When it's too high, it actually decreases excitability. That's why we see muscle weakness, depressed reflexes, ileus, constipation, and lethargy. High calcium also interferes with the kidney's ability to concentrate urine, leading to polyuria and dehydration, which then worsens the hyperkalemia. In cancer, tumors can secrete parathyroid hormone-related peptide, mimicking parathyroid hormone and driving calcium higher. Treatment begins with aggressive intravenous fluids to expand her volume and help flush calcium. A loop diuretic is only used if she develops volume overload. Intravenous bisphosphonates are started early to block bone breakdown, while calcitonin provides a rapid but temporary effect. In patients with kidney failure, denosumab can be considered. Dialysis remains an option if her kidneys cannot clear the calcium. The physician explains gently to her daughter, "Her calcium is very high, likely from her cancer. We're giving fluids to flush it out and medicines to bring it down. This is serious, but we are treating it right away." Hypomagnesemia, low magnesium. Paramedics are called to a shelter for a 52-year-old man with a seizure. Staff explain, he has a history of heavy alcohol use. He's been vomiting for days and hasn't eaten much. When the paramedics arrive, he is postictal and restless. He trembles with shaking hands and struggles to answer questions. On exam, they see fine tremors and eyelid twitching. His calves are cramping. He is confused and agitated. Vitals are called out. Heart rate is 118. Blood pressure is 140/90. Respirations are 24. During transport, he becomes more agitated, then has another tonic-clonic seizure. The team manages his airway, gives oxygen, and secures intravenous access. They suspect a severe electrolyte disturbance, likely related to alcohol use and malnutrition. At the hospital, the handoff is given. Middle-aged male, chronic alcohol use, poor nutrition, vomiting. Seizures ×2. Tremors, agitation, tachycardic and hypertensive. Possible hypomagnesemia. The labs confirm it. Magnesium is 0.3 millimoles per liter, dangerously low. The physician explains to the residents, magnesium is critical for neuromuscular stability and acts as a cofactor for many enzymes. When it's low, there's increased acetylcholine release, leading to tremors, twitching, and seizures. Low magnesium also impairs parathyroid hormone release, which causes secondary hypokalemia and makes tetany worse. In the heart, hypomagnesemia predisposes to torsades de pointes and other arrhythmias. Alcoholism and vomiting caused low intake and high losses in this patient. Treatment begins with intravenous magnesium sulfate, given as a bolus followed by continuous infusion. The patient is placed on cardiac monitoring to watch for dangerous rhythms. Potassium is also checked and replaced if low, because magnesium deficiency prevents potassium reabsorption. Thiamine is given to prevent Wernicke's encephalopathy as part of alcohol withdrawal care. The nurse reassures the shelter staff, his seizures were triggered by dangerously low magnesium. We've started IV magnesium, and it usually works quickly to calm tremors and stabilize the heart. Hypermagnesemia. High magnesium. Paramedics are called to the home of a 76-year-old woman. Her daughter explains she has kidney problems. She's been constipated and has been taking a lot of milk of magnesia lately. Today, she's barely waking up. The paramedics find her lying in bed, barely responsive. Her breathing is slow. Her skin is flushed and warm. On exam, her reflexes are nearly absent. Her muscles are weak and floppy. She is drowsy, with slurred responses. Vitals are called out. Heart rate is 48. Blood pressure is 80/50. Respirations are 10 per minute. During transport, she becomes less responsive, almost comatose. On the monitor, her QRS is widened and her PR interval is prolonged. The team begins assisted ventilation, secures intravenous access, and radios ahead. Severe bradycardia, likely electrolyte disturbance. History of chronic kidney disease, heavy magnesium laxative use. At the hospital, the handoff is given. Elderly female, chronic kidney disease. Excess use of milk of magnesia. Found drowsy, hypotensive, bradycardic, with absent reflexes. Widened QRS on the monitor. Suspected hypermagnesemia. The labs confirm it. Magnesium is 2.8 millimoles per liter, elevated. The physician explains to the residents. Magnesium normally calms neuromuscular excitability. Too much magnesium depresses acetylcholine release at the neuromuscular junction, leading to weakness, hyporeflexia, and respiratory depression. In the heart, high magnesium slows conduction, causing bradycardia, AV block, and risk of cardiac arrest. Her kidneys can't excrete magnesium effectively, and excess intake pushed her into toxicity. Treatment begins immediately with intravenous calcium gluconate to stabilize the cardiac conduction system. She is given intravenous fluids and a loop diuretic to promote magnesium excretion, though dialysis may be required because of her kidney failure. She is placed on continuous cardiac and respiratory monitoring with airway support as needed. The physician explains to her daughter, her magnesium built up because her kidneys can't clear it well. We're protecting her heart with calcium and working to remove the excess magnesium from her system. Hypokalemia, low chloride. Paramedics are called to a nursing home for a 79-year-old man with weakness and confusion. Staff explain, he's been vomiting for several days, hardly keeping anything down. He has heart failure and takes a water pill. When the paramedics arrive, they find him pale and frail, sitting up in bed. He looks restless and clutches his stomach. On exam, his lips are dry and cracked. His breathing is slow and shallow. His hands tremble with occasional cramps. Vitals are called out. Heart rate 110. Blood pressure 90/55. Respirations 10 per minute. Oxygen saturation 95%. During transport, his breathing becomes slower and irregular. He is less responsive, drifting toward sleep. The paramedics suspect an electrolyte imbalance with acid-base disturbance. At the emergency department, the handoff is given. Elderly male. History of congestive heart failure. On loop diuretic. Several days of vomiting. Weak, tremors, slow breathing. Blood pressure 90/55. Heart rate 110. Suspected hypochloremic metabolic alkalosis. The labs confirm it. Chloride is 85 millimoles per liter, low. Arterial blood gases show a metabolic alkalosis. The physician explains to the residents, chloride is the main extracellular anion, important for acid-base balance. Vomiting leads to loss of hydrochloric acid. Low chloride means less sodium is reabsorbed with chloride in the kidney. Instead, sodium is reabsorbed with bicarbonate, which raises bicarbonate levels and causes metabolic alkalosis. That explains his slow breathing. The respiratory system is trying to compensate. Alkalosis and associated electrolyte shifts contributes to his muscle cramps and weakness. Treatment is started with intravenous normal saline to replace sodium and chloride and correct the alkalosis. Potassium chloride is added if potassium is low. Antiemetics are given to stop further vomiting, and electrolytes are monitored closely. The nurse explains to the nursing home staff, his low chloride from vomiting made his blood too alkaline. That's why his breathing slowed down. The fourth saline will help restore balance. Hyperkalemia. High chloride. Paramedics are called to a rehabilitation facility for a 62-year-old man who has suddenly become confused and is breathing rapidly. Staff explain he has chronic kidney disease. Last week he was dehydrated, and they gave him a lot of intravenous fluids. When the paramedics arrive, they find him sitting forward, restless and flushed. He is breathing fast and deep, almost like air hunger. On exam, his mucous membranes are dry. He answers questions slowly, sometimes not making sense. Vitals are called out: heart rate 102, blood pressure 105/70, respirations 28 per minute, oxygen saturation 97%. During transport, his breathing remains rapid and deep. On the monitor, he is in sinus tachycardia. The paramedics suspect a metabolic problem and radio ahead. Patient with kidney disease, recent intravenous fluids, confused, tachypneic, and flushed. Possible metabolic acidosis. At the hospital, the handoff is given. Male, 62. History of chronic kidney disease. Received large volumes of normal saline for dehydration. Now confused, flushed, tachypneic, with rapid and deep compensation respirations. Suspect hyperchloremic metabolic acidosis. The labs confirm it. Chloride is 115 millimoles per liter, elevated. Arterial blood gases show a normal anion gap metabolic acidosis. The physician explains to the residents, chloride balances bicarbonate in the blood. When large volumes of normal saline are given, chloride rises and the kidneys excrete bicarbonate to keep electroneutrality. The result is a hyperchloremic metabolic acidosis. His kidneys cannot compensate effectively because of chronic kidney disease. That's why he is hyperventilating, to blow off carbon dioxide and buffer the acidosis. Treatment begins with stopping normal saline and switching to a balanced crystalloid, such as Ringer's lactate or plasmolite. Supportive care continues, with bicarbonate given if acidosis is severe. Dialysis is considered if his kidney function cannot clear the excess chloride. The nurse explains to the rehab staff, his chloride got too high from all the saline, which threw off his acid-base balance. That's why he's breathing so fast. We've switched his fluids and are correcting it. Hypophosphatemia, low phosphate. Paramedics are called to the home of a 39-year-old man who has collapsed. His roommate explains, he has HIV. He hasn't been eating well. He was in the hospital last week with pneumonia and just started tube feeds yesterday. Today he's so weak he can barely breathe. The paramedics find him alert but exhausted, struggling with each breath. He says weakly, "My legs feel like jelly." On exam, he has profound muscle weakness and shallow, rapid breathing. He seems confused and unable to focus. Vitals are called out: heart rate 124, blood pressure 95/60, respirations 32 per minute, oxygen saturation 92%. During transport, his breathing worsens. His chest rises only slightly with each breath, and his oxygen saturation drifts lower. High-flow oxygen is applied, intravenous access is established, and the team prepares for possible assisted ventilation. At the emergency department, the handoff is given. Male, 39. HIV positive. Malnourished. Recently started tube feeding. Found with profound weakness, shallow breathing, confusion, and low blood pressure. Suspected severe electrolyte disturbance. The labs confirm it. Phosphate is 0.3 millimoles per liter, dangerously low. The physician explains to the residents, phosphate is essential for ATP production and for 2 to 3 BPG in red blood cells. Without phosphate, ATP drops and muscles cannot function. That includes the respiratory muscles, which explains his shallow breathing and fatigue. Low 2-3 BPG means hemoglobin holds on to oxygen too tightly, causing tissue hypoxia even if oxygen saturation looks normal. In this case, malnutrition followed by sudden tube feeding caused insulin release, which shifted phosphate into cells. That's refeeding syndrome. Treatment begins with intravenous phosphate replacement, given carefully to avoid calcium phosphate precipitation. Ventilatory support is prepared as needed. Potassium and magnesium are checked and replaced if low, since these often shift alongside phosphate. His tube feeding regimen is adjusted to reintroduce calories gradually and prevent recurrence. The nurse explains to his roommate, his phosphate dropped dangerously low when his body started processing the tube feeds. Without phosphate, muscles, even his breathing muscles, can't work properly. We're replacing it now and supporting his breathing until he improves. Hyperphosphatemia. High phosphate. Paramedics are called after a 55-year-old man with kidney failure collapses at home. His wife says, he missed 2 dialysis sessions this week. He's been weak, complaining of tingling around his mouth and muscle cramps. Today, he started twitching and even lost consciousness for a few seconds. When the paramedics arrive, he is anxious and trembling, with his hands clenched into a claw-like spasm. On exam, he has carpopetal spasm, facial twitching, and painful muscle cramps. Vitals are called out. Heart rate 105. Blood pressure 150/90. Respirations 24 per minute. During transport, his spasms worsen, and he nearly seizes. Oxygen is given, intravenous access secured, and the team radios ahead. Male with end-stage renal disease, missed dialysis, tetany-like symptoms. Suspected high phosphate with low calcium. At the hospital, the handoff is given. Male, 55. History of end-stage renal disease. Missed dialysis. Found with weakness, cramps, paresthesias, and carpopetal spasm. Tachycardic and hypertensive. Nearly seized en route. Suspected phosphate-calcium imbalance. The labs confirm it. Phosphate is 2.8 millimoles per liter, elevated. Calcium is 1.7 millimoles per liter, low. The physician explains to the residents, phosphate is normally cleared by the kidneys. In renal failure, phosphate accumulates. High phosphate binds calcium, forming calcium phosphate complexes that precipitate in tissues. This lowers ionized calcium, causing tetany, spasms, and seizures. Chronic buildup also calcifies blood vessels and soft tissues. His blood gases show a metabolic acidosis, common in kidney disease, which worsens the imbalance. Treatment begins with intravenous calcium gluconate to stabilize neuromuscular excitability. Phosphate binders are prescribed to reduce absorption from the gut. Hemodialysis is arranged to clear phosphate. Correction of acidosis is planned as part of his dialysis. The nurse reassures his wife. His phosphate is very high, and that dragged his calcium down, causing the spasms. Dialysis will clear it and restore the balance.